We can start. Awesome. Great. I'll move that over there. Okay. All right. So thank you guys for joining us again for another episode of Probing the Literature, the Ultrasound Journal Club for the ACEP Emergency Ultrasound section and the SAEM Academy of Emergency Ultrasound. And today our schedule is going to be, we're a few minutes late, but we're going to be going over 2 articles. So our first article is going to be with our awesome author who's going to be presenting and talking about her article. So please think of some ideas or questions that you want to ask her, and then we'll break into small groups. And then finally, we'll end at 3 o'clock with the methods consult. So anyone who has any research ideas or whatnot, please join us. All right, just make sure that you're muting yourself. And if we can, if all of our people who are fellows or for faculty, just kind of put that in your screen name so we can know when we get into small groups. It just makes it a little bit easier for us to chat. So our first article is going to be the utility of point-of-care ultrasound, lung ultrasound for evaluating acute chest syndrome in young patients with sickle cell disease. And so this is a pretty awesome article. I'm excited to welcome Stephanie Cohen. She is going to be our speaker today. She is the lead author on this paper, and she is an assistant professor of pediatrics and emergency medicine at Emerg University. And she's an attending physician and director of point-of-care ultrasound for pediatric emergency medicine at Children's Healthcare of Atlanta. She completed a residency at the Robert Wood Johnson Medical School, of fellowship in pediatric emergency medicine and ultrasound training at Newark Beth Israel Medical Center. And her research focuses on thoracic and abdominal ultrasound. And she is also on the executive board for the P2, which is the PEM POCUS network. And she's the POCUS chair-elect for the American Academy of Pediatrics. So she does a lot of great ultrasound work. And in her free time, she likes spending time with her 5 children and competing in triathlons. And she just finished recently a sprint Olympic and half Ironman distance of 70.3 World Championships in St. George, Utah, which is pretty awesome. I can't even imagine running that far. So welcome, Dr. Cohen, and we'd love to have you go ahead and tell us about your article. I'm going to stop sharing so you can take over.
Thank you so much, Petra, and thank you for inviting me to talk today. And first, I want to just say it's so nice to see so many familiar faces and names on the screen here. Share my screen. Okay, give me one more second. All right, give me one more second. Let me just see what's wrong.
Some previous presenters have run into this problem as well. If you present from this current view, people have done that in the past.
No, that's not what I'm trying to do.
Screen ratio.
Sorry? I'm sorry, can you say that one more time?
You're muted, Dan.
If you want to go back to the view where you brought the one screen over to the side, that's fine.
Yeah.
If at least part of it.
All right. Okay, so we'll talk a little bit about that in a few minutes, but one of the reasons why I think this is really an ideal, I guess, pathology or study subject is just that it is so prevalent in the patients that we see. And it also has a significant morbidity and mortality for patients. So it's really something that you don't want to miss in your patients, something that you really want to identify. So acute chest syndrome, the findings can be very variable and very difficult and nonspecific in children. Patients can have fever, they can be afebrile, they can have chest pain with or without respiratory symptoms. And so physical examination is going to be very difficult with these patients and pediatric patients in specific. And previous studies that were looking at physical examination for patients with acute chest syndrome showed that the physical exam was very nonspecific. And in about 50% of patients, physical exam was really not able to identify acute chest syndrome. And so based on these findings, chest X-ray became the standard for diagnosing these patients. And it is part of the definition of acute chest syndrome is that there is consolidation on chest X-ray. The studies have shown that children can have greater than 25 chest X-rays by the time they reach their 18th birthday, and about 5% of patients are getting over 100 chest X-rays. And so the cumulative radiation is really what we're concerned about here. And so that's why when we started thinking about how to approach this with our patients, chest X-ray seemed like a very novel way to approach this. And we know it had been previously used in patients with pneumonia and in the ICU. And so this is really why we started this project. Just to give you a little bit about background about where we're coming from, this is a schematic of our new children's hospital. This is the Arthur M. Blank Hospital, which is set to open in possibly 2025, possibly in the fall of 2024. And this is going to be a freestanding children's hospital consisting of almost 450 beds with an emergency department of almost 70 beds with 6 trauma rooms. So pretty significant size. And that tells you just a little bit about the population that we're seeing here in Atlanta. We have one of the largest sickle cell centers in the country with almost just over 2,000 patients. And during the last couple of years, we are having almost 2,000 visits a year for patients who are coming in with complaints of pain, and about 700 visits a year for patients who are coming in with fever. And our prevalence of acute chest syndrome in this population is about 17%. So that's pretty high. And so we had the volume and we had the prevalence of disease. And so based on these factors, this was something that we thought would be good to study in our center. So in looking at the research questions, really the first question was to see how well POCUS would be able to identify our patients with acute chest syndrome. And that's really what, the primary what we wanted to see, but we also wanted to try to see if there were other factors that we could take out of the study. And that included using novice sonographers. A lot of the early ultrasound research really looked at the experts. And so we really want to know, how is the common person able to use ultrasound? And it also lends to its generalizability to other centers. And one of the things that, as we were talking to our hematologist, was, how these are the kids who are coming in with pain. And so how well are they going to tolerate this exam? They're already in pain. It's already going to hurt them to be touched. And so this was another factor that I threw in, not only to just try to see how the patients tolerated the exam, but also kind of, we're doing this study in conjunction with our specialist, but in some ways we had to sell it to our specialist. So that was another feature that I put into, again, to show how well the patients would be able to tolerate it. So this was a prospective observational study that took place at 2 of our centers. We have a tertiary quaternary center that's kind of in the just suburban area, and then we have a in our downtown more rural area. So patients who presented to either of these 2 locations when one of the study sonographers was available. So this was a convenient sample of patients. The sonographers would enroll the families, enroll the patient, and the goal was to perform the POCUS before the patient received a chest X-ray. In cases where they were not able to enroll the patient prior, they were blinded to any chest X-ray results. And chest X-ray and the interpretation by the pediatric radiologist was the reference standard in this case. One of the, I don't want to say complications, but one of the factors that we really took into account in terms of our data was how do we use equivocal chest X-rays, because unfortunately that is a reality when we're using radiology. And so we considered equivocal chest X-rays as negative, so we wouldn't inflate any of our performance characteristics. And then after the scan was completed, the parents were asked to fill out a patient satisfaction survey to see how well their child tolerated the examination. And we did also put in questions similar to prior patient satisfaction studies that also included how they saw their care in the emergency department. So one thing I want to just mention about who were the study sonographers, when you're performing prospective studies, it's really important to see who's going to be your workforce. And in many studies that have been done, the sonographers have included other faculty, residents, and unfortunately, that's something that I didn't have in this case. But one thing that I did have is that here at Emory University, our medical students have a required research program. It's called their Discovery rotation. And that's a 5-month block where they are required to do ultrasound. So we were fortunately able to submit for this project, and we were able to get these Discovery students who were able to spend 5 months in our emergency department enrolling patients. So that was really, really great for us. Their study, their training program was similar to other studies. They received an hour lecture time, an hour hands-on practice, and then prior to enrolling, they did 5 practice scans. And as far as the scanning protocol, that again followed other similar, other previous research protocols. And they scanned, again, the entire chest, anterior, lateral, and posterior. And one of the things that I was pretty particular on, I'm not sure how other people scan, and you guys can tell me when we're finished, is I generally like to identify the diaphragm first, and then scan from the diaphragm cephalad, because I feel like they're less likely to misinterpret the liver and or the stomach on the left side. So we included any patient who presented to the emergency department where there was a concern for acute chest syndrome. So if they came in with fever, if there was presence of URI symptoms, hypoxia, or chest pain. So patients did not necessarily need to have fever. They could be afebrile again if one of these other symptoms were present. And also if they were getting a chest X-ray. We excluded any patient who required critical care, or if they had a previously known chest X-ray that was obtained during the visit or transferred from an outside institution. So here are our results, and we broke down the results to the novice interpretation, and then looking at the blinded review. So just first looking at the performance characteristics of the novice interpretation, it did show good accuracy, 89%, had good likelihood ratio, positive and negative likelihood ratio. And the sensitivity was a little bit lower than we were expecting, but again, these were novice sonographers. One thing, and I'll just mention it now, we did not look at their performance over time. So I know some studies have looked at how the sonographers performed in the first half versus the second half of the study. That isn't something that we looked at, so this was more cumulative. And then all of the studies were reviewed by the blinded expert, myself, and just to show the performance of ultrasound as an overall. And so again, that improved ultrasound focus overall had a mildly improved accuracy and sensitivity of 88% and specificity of 93%. So this is very much in line with previous studies that we had seen, and still pretty good negative predictive values. So I mentioned that we wanted to see how our novice sonographers performed, and we did assess agreement between the novice sonographers and the blinded review. And we did find a moderate kappa of 0.67. And just looking at some of the discordant findings, we had 11 false positives where the POCUS was interpreted as positive, but the chest X-ray was negative. And one of the things that I hadn't really taken into account when we first started was the presence, again, with patients with sickle cell disease, that they do have chronic lung disease. And I really was not, didn't really think ahead about how scarring might appear on POCUS. And so that was one of the factors that led to false positive findings in our population. One was an equivocal chest X-ray, which again, we had interpreted, we put forth in our definition that those would be negative. We still, even though we tried to follow an organized scanning technique, again, there were still a few times where the novice sonographers mistook the stomach and spleen for consolidation. And then there were a few, there were three cases where the POCUS was read as positive, but on chest X-ray, they were actually read as less than 1 centimeter. And what's interesting about those patients is that 3 of these patients were actually hospitalized and then did go on to develop acute chest syndrome. So the question kind of leads is, could POCUS diagnose acute chest syndrome earlier, which we have seen in other studies. And you know, maybe this is something we can use down the road for screening. There were a few false negatives, and 3 of those were from just missed findings by the novice sonographers, which were picked up on blinded review, and then the 4th was just did not pick up the consolidation at all. So just looking at the patient satisfaction, again, this was one area that I was very interested in, and overwhelmingly, the patients were very satisfied with the care they received, and many even said that it enhanced their visit in the emergency department. And I think this really, again, is similar to previous studies where patients who received POCUS felt that they were receiving better care. I think that it wasn't 100% because, unfortunately, these were novice sonographers, and we weren't using the information for patient care. So that might have been a little frustrating because we weren't making any clinical decisions based on these findings. But overwhelmingly, they felt like they were receiving better care. And 90% of patients denied having any pain. There was only 1 patient who withdrew from the study because of pain. So I'm not sure what happened to the other 10%. I do know that with some of the younger patients, you know, sometimes little children, you know, they don't like to be touched. Maybe they cried a little bit, and that might have influenced the parents' responses. So just in looking at these findings, I think that that the results show nicely that POCUS can be used as an alternative imaging study to chest X-ray, and I think that with the use of novice sonographers, I think that we can say that this can be highly generalizable to other sites, and you know, something that we should start using regularly. The question I mentioned earlier is, can this be used to detect acute chest syndrome earlier? There is another study that did look at this, and again, I think this is something, you know, we know that POCUS can detect consolidation sooner than chest X-ray. Chest X-ray lags the clinical picture. And this is something that, again, I think should be evaluated. And the other, I think, strength is that we did have good patient satisfaction. So patients not only tolerated the exam, but it really, they were highly satisfied, and that it improved their impression of their care in the emergency department. So, as you're going through a study and you're creating and you're looking at your data and interpretations, there are always things that you feel like you missed, and maybe you should have thought about. And there were a lot of other factors and variables that we did record. We did record duration of the scan, but it was hard in terms of the overall visit to look at length of stay, because sometimes the scans were performed before the chest X-ray, sometimes after. But again, at the end of the day, this was a convenient sample of patients. So there may have been some degree of selection bias. We were using a chest X-ray, which is the generally accepted use for acute chest syndrome, but we know that chest X-rays are not a perfect reference standard, especially in my experience. I'm seeing our radiologists more and more hedging as far as their equivocal interpretations. I mentioned before the chronic lung changes. Again, this was something that I was really not anticipating before for the study. And because our sonographers and reviewers were blinded, they were not able to, they weren't able to compare to either prior POCUS or prior chest X-ray, whereas radiologists are able, when they're reading their chest X-rays, can compare to previous studies. So this is something going forward that would be interesting to be able to compare to previous studies that might have decreased that number. And we did, as much as we did try to blind our sonographers to any findings, they were blinded to the physical exam findings. But of course, and this is one of the advantages of POCUS, is that you're at the bedside and you can see the patient, but they were not blinded to signs of tachypnea, retraction. And of course, the monitors in the room, they could see if there was any signs, change in oxygen saturation. And again, like I mentioned, there were other variables that we would have liked to have reported on. And again, we did record the length of the study, but we didn't analyze how this impacted length of stay in the emergency department. So some next steps into looking at this is to evaluate using POCUS to do serial scans. Generally now, patients who are admitted, or if there's concern for acute chest syndrome, they will get serial chest X-rays until the chest X-ray is either positive or symptoms resolve. And so in this case, I think that doing serial lung POCUS would be a nice way to evaluate these patients rather than expose them to more radiation. Again, even though we used novice sonographers, and I think that really lends to the generalizability of this application, I think that doing a multi-institutional study across the country in various sites would really be able to help determine how this can be used in the emergency department. And then the next step, help to develop clinical algorithms and who would be the appropriate patients to get a lung POCUS. So just take-home points. Again, I think POCUS is a nice imaging modality that can detect acute chest syndrome. It is highly accurate. It is has a good specificity. I think we still need to determine how we are going to use that clinically. Is that going to be generally used for all patients? Is it going to be a screening test? And again, those are where future studies may be helpful. And it's well tolerated in patients. There's no increased problems with pain, and there was definitely a high satisfaction with our population. So, these studies are sometimes very long. We had actually finished the study for a few years before it was published, and I wasn't really sure where we were going. And fortunately, we were able to pull this together and get this out. So, I think that sometimes we really can't see the fruits of our labor, and it takes a little bit of time until these things get together. And with that, I just want to say thank you, and I'm open for any questions.
Thank you, Stephanie, so much for presenting that. I think that this is actually a really great opportunity for us to discuss this. There's a question in the chat. So what was the average / approximate time it took to complete each of these scans?
Okay, sorry. I'd have to go back to the data, the data set, but I'm want to say about 7 minutes. And again, that may seem long for, you know, the lung study is a little bit more involved because you do need to scan, you know, anterior, lateral, posterior on both sides. And sometimes it may be a little bit longer in children. But I want to say it was probably about an average of 7 minutes.
Do you think that time may have been shorter if you had more experienced sonographers?
Yeah, again, like I mentioned before, we didn't do an interim evaluation of their progress throughout the period. But I, you know, some of them again were shorter, but I do think that if we had, that's one of the variables we could have evaluated.
Great. Does anybody else have any questions?
I had a question real quick, Stephanie. Hi, Stephanie. I had a quick question. You'd mentioned some chronic lung disease, you know, with this population. Like, how big of a problem did you find that to be? Like, what were the issues that hung people up? Because it seemed like, you know, it was consolidation or sort of not on your reporting. It wasn't like, oh, there's a bunch of fibrosis, or hey, this could be B-lines and edema. You know, at least in the data collection. Were you experiencing that sort of like, I guess, qualitatively from the scanners, or was it just something that they brought up? Or
this is something that we found more so from radiology. You know, like, you know, when we think about when I was approaching the project initially, I was just kind of thinking about you know, just kind of lung consolidation from an acute process. But we know that patients with sickle cell disease do have recurrent episodes, and so there's recurrent, you know, recurrent damage, recurrent to the lungs, to the blood vessels in the pulmonary vasculature. This came up. It didn't come up that often. It was only a handful of patients, but it is something that I wasn't, you know, just in terms of planning ahead, just wasn't kind of thinking about how that was going to present on POCUS. I don't know if that makes sense, you know, kind of what chronic lung disease on POCUS looks like. It's kind of, I mean, even though we see children with, you know, chronic lung disease from prematurity, it's just not something that, you know, typically we were, you know, not something I was thinking of more acute processes as we were planning ahead.
Yeah, it looks like someone also asked, looking retrospectively, can you tell scar tissue from acute chest X-ray or from acute chest on ultrasound?
Yeah, so again, that's something that, you know, again, we were based on previous studies, we were using consolidated tissue greater than 1 centimeter. And I know Sam is the expert on lung ultrasound, but again, it's something that, again, we only had a handful of patients, so it's not something that we could have delved deeper into this population. But I think if we, with larger numbers and multi-institutional studies, it may be something that we can look at.
Great question there. Another question we had was there any buy-in from hematology to accept or to adopt POCUS instead of chest X-ray?
So, so at this point, I wouldn't say instead of, but maybe in you know, I'm not saying conjunction, but again, maybe more as a screening test. And I think that patient satisfaction, that was one of the big questions as we rolled the study out. They're like, well, you know, how do we know they're going to tolerate it? How, you know, how do we know? And so for hematology, that was a really big selling point when we could show them that, yes, the patients, not only did they tolerate it, but they really, it enhanced their care. And so that was a big selling point for them. And I think I would say it depending on I think we need to work a little bit more closely with our hematologists. At our institution right now, our hematologists are not admitting patients without a chest X-ray. But I think that if we increase the volume of lung focus that we're doing, I think eventually we will move to that point.
Yeah, I think that's like so many things with POCUS, right? It's like you have to get the buy-in, like you have to demonstrate that this is actually really awesome and for, you know, and can actually benefit your patients. But it's interesting that you said that they were more concerned about if the patient would tolerate it than the actual findings. So that's really kind of interesting that was what they were, hang up was. And then one, go ahead, sorry, continue.
Oh, no, I think, again, like, just like you said, buy-in, everything that you do, you have to sell. And so that was just a huge selling point.
I think we have got one more question, and then I think we can go to our small groups after that. But were there any significant differences between the linear probe exams and the curvilinear probe exams? Did you find any major difference there?
I didn't really look at that. It was just, you're viewing the studies based on the studies. The linear transducer was used for smaller patients, and curvilinear transducer was used for larger patients, and and based on sonographer preference. So it wasn't really based on the transducer itself, more so the study.
All right. Any other questions from the audience? Awesome. Well, I want to thank you again, Stephanie, for coming on. I really appreciate it. And we're going to move on to our next lecture or next article, and that's going to be a small group session. And so our next article is also going to be Stephanie's part of the P2 network. So this is actually a study that was also part of the P2 network. And so this next one is going to be diagnostic accuracy of point-of-care ultrasound for intussusception, a multi-center non-inferiority study of paired diagnostic tests. And so we have, let's see, our instructors today, we got Andrew Shannon, Dr. Leka Shaw from Emory, Monica Luciak, Nikolai Schneid, and Benjamin and Ninti. Sorry if I'm saying that wrong. So we're going to break into some small groups and hopefully have a good discussion. And then when you're in your small groups, we're going to just kind of think of one point that was really important to your group, because when we come back for the last few minutes, we're just kind of take and summarize any important points that you thought in your group was something relevant about that article. Dan, are you ready to break us up?
You got it. Some rooms.
So we are all back here. Hopefully everybody had a good discussion about the article. And then maybe we can kind of hit on what everybody thought, or one salient point that your group came up with about the article, so that we can kind of start a little bit more of a discussion here. I'm just going to randomly call on people because I can see you. So Nikolai, I can see you first. So I'm going to call on you first. What did your group come with? What was their, let's see, do we get everybody back? Hold on. Everybody's not back yet. Didn't know we were all back. Everybody back in, Dan?
Hey,
everyone's back in now.
Sorry,
Yeah.
I've got to run to pick up a child, but it was really fun. Thank you so much for inviting
Thank you
me.
so much, Lake. I really appreciate it. Thank you for pitching in.
I'm going to punt to Roger, who kind of caught on to this thing pretty quickly. That took me a couple of kind of looks at this article to be like, whoa, that's interesting. So.
Yeah, so hi. So basically, we focus on the methodologies of this study. And what's interesting for us that actually we got these sonologies that they chose to perform the ultrasound. Actually, they have really basic, different experience levels, because we got people that only had 20 abdominal ultrasound with one positive intussusception, to people that had RDMN certification or fellowship trained people. So actually, it was huge for us, because it says that actually people with lower level experience is pretty accurate. And actually, it was really great that they mentioned the confidence level that they had when they performed the ultrasound, and actually stay in the 94% accuracy, even though they have low experience. And also, we mentioned that it's important for us that actually people that were discharged home that had complications after this, we actually saw something in the ultrasound. So we didn't send them home not knowing something or just a false negative. So That's good. I think that give us diversity on who can perform the ultrasound. It give us confidence to establish this in our everyday practice.
Yeah, I think that's a really good point. We were kind of mentioning that too, and that, as far as you think of generalizability, as far as, novice sonologists versus someone who's more experienced. So, this would be an interesting study to repeat again once you had, if you were, just training residents and whatnot later on. But I think you've got to get people to adopt this particular, kind of start using this instead of just going to the radiology scan. And Nikolai pointed in the chat, the video is actually really great. I think that I clicked on that and it was, actually quite useful, I thought, for just educational purposes. Not only I think this was awesome that they made this for all of their enrollees, but I thought that was actually pretty useful for us to, if you look at that and you're like, oh, we were having this discussion in our group about how, Stephanie and I were talking about how I was always taught to start in the right lower quadrant and do the lawnmower technique. And that how she was actually in the study, one of the sites, and said that, that actually changed her management, and that she changed her technique to follow more of that, the colon, as opposed to doing that lawnmower technique. So I thought that was actually kind of a nice benefit too, that this may have actually kind of improved people's visualization because they're all doing it the exact same way, which I thought was actually great as well. Let's see, Andrew Shannon, what did your group, any salient points you want to mention?
Sure. I'll kick it over to Alex's group. His resident made a point, I think along the lines like we all have with ultrasound research in terms of the operators. So yeah.
Yeah, go for it. We talked very similarly along those lines about sonographer experience, because potentially we could graduate from residency being pretty close to that 20 belly scans with a positive 1 scan, right? But I would not consider myself to be on the same level as somebody who had completed an ultrasound fellowship. So just wondering about interreliability between sonographers on either end of the spectrum. And then we talked about how you could potentially stratify by training level within the study that was already performed, and then also within studies moving forward.
Yep.
Actually, I just want to make a comment. I was part of the study too, and then we actually published another study on inter-rater reliability in pediatric emergency care. So you can actually look at the inter-rater reliability, and it's moderate. It's not great, but it's like everything else in ultrasound, moderate.
Yeah, I mean, I think that that's a great point. And I forgot about that fact, but I saw that article as well, Sam. So thank you for bringing that up. That's a good one. We make sure to drop that in the chat too. Monica, what did your group come up with?
Well, the biggest question we had, and maybe Sam can tell us, is we wanted to know who A1 was, because that person did over 50 scans on the one that was enrolled over 50 people. We were pretty impressed. And Bryson said that person would he would buy them a drink of their choice. So
yeah, I know it's a main site. It's at the main site. I'm not quite sure. I think we have a guess who that person would be, but it's at the main site, which is Children's Minnesota.
But I don't. So Children's Minnesota was the main site, but I think that they had more than one. I think one of the reasons why they had a lot of like I talked about before, resources. They had research assistants there, and I don't think it was just one person enrolling. I think that they had several POCUS people there, but they did have research assistants so that they could enroll more patients.
Yeah, I think what was impressive was actually the Costa Rica site. They didn't have that much support, and they actually had very high positive rate. That was actually the other site that actually had a high positive rate if you read the article.
Yeah, and if you go into, they did a great job in this article of really giving you a lot of references as far as extra content, which was like a whole deep dive for me too, to kind of go into and be like, oh my gosh, look at all this. You could see exactly who did what. So I think this was great, and that it really kind of laid things out for you really, really well, which I was actually impressed about. Who else had a group? Oh, Benjamin, do you want to tell us about what you guys discussed?
Yeah, I think we try to just kind of look at sort of that clinical relevance to the entire article itself, right? And I think one of the most difficult things to do in some of the articles that we read is to not have these studies that are just kind of geared looking at how the trained sonographers can use this. Then we tend to just divide ourselves a little bit. Eventually our colleagues are going to be saying, well, I'm not fellowship trained, so I can't go ahead and do this, right? And so we just have to try to, if this study is speaking to a larger issue, then it should be able to translate right then to those that are not trained, right? And so how do you get the guy that is maybe credentialed to use it, or the gal that's credentialed to use it in your ED as a physician, as faculty, maybe a fellow, whatever the case may be, and that they're being able to use it and they can still have that same effect? Well, because if you look at this non-inferiority study, you're looking at it with people that are sort of experts in their field doing this. So yes, it's at the bedside, it's functional, it's great. I can show you that can do it, but can you translate it to somebody who is a novice or who doesn't have much clue, and how long does it take for them to do it, and can they achieve the same results as the radiology? So I think that's where we're kind of just talking about the difficulty with that. And we know that it's a step in the right direction, but I think there's more work to do to be able to sell this idea to our colleagues.
Yeah, I agree. I think that's kind of, looking at the two studies that we just discussed, that's, you kind of have to start at some jumping off point. And so I think that just proving that even, we can be just as good as radiologists, and then being able to, the next step is to do that, generalizability for, can a novice sonologist do this as well and come up with the exact same results? I think you're absolutely right on that. Absolutely.
So
right.
I will speak from a site that's a community hospital that really has minimal pediatrics. And if there's any pediatrics that has to be admitted, it has to be transferred out to a children's hospital. As I was talking with our group, I think the way to apply this is, if you find a positive, it's a lot easier to transfer that person. And whether they go to, the children's hospital and they have a confirmatory scan or another comprehensive radiology performed scan, that's that site's option. But when you're able to call them and you say, I saw intussusception, or I saw pyloric stenosis, or I saw an appendicitis, it's a lot easier to get that person transferred. So even at least some basic skills in giving some comfort to non-PEM trained or even not fellowship trained EM docs, I think is very, very helpful, because at least if they look for it, potentially it could help them with the transfer part of it.
Absolutely. Absolutely. I completely agree on that. All right. Well, we are winding up this segment of Probing the Literature. And so we are welcome anyone to stay for our next segment. It's the methods consult. And so if you're not familiar with the methods consult, what we do is we're actually looking for anyone or to discuss anyone's ideas, current research. If you want to get some thoughts on, from the community about your research or an idea you have, we're happy to listen to it and kind of give any feedback. The only other thing I will say is, if our next session is going to be pulmonary. And so keep posted for what articles we'll be having next. And then if you want to volunteer to be a small group instructor, I'm going to put the form for volunteering in the chat. So if you in the future would like to help us out, then we would love to have you guys join us as an instructor as well. So by that, thank you to Stephanie for coming today and presenting her article, and thanks for all of our small group instructors. I really appreciate you guys stepping in and leading these groups, and we'll hope to see you joining us again in the future. And then we're going to start with our methods consult. Does anyone have anything that they would like to discuss? And thank you, Dan, for always running this with such, you've got this down to a science. And I love it.
The gears spinning are like amazing.
I know he's a well-oiled machine now.
I had a methods question kind of for Sam, if Sam is still on. I see the camera's off. This study that you had, we talked about this in our small group a little bit, that when you have so many sites and so many sonologists, and I like that there's sonologists and not sonographers. I really like that one. You know, there's a lot of questions about like, how does this heterogeneity affect my generalizability? And y'all did a lot of stats and modeling to kind of account for that. That is always a little bit, a lot of bit above my head, but I can kind of like, I feel like I'm at a point where I can say, okay, like this seems to be the right thing to do when you're dealing with this kind of heterogeneity. Can you talk a little bit about like when in the process you got a statistician involved, how that statistician guided your analysis? And then one of the things, it's really hard for us to find a statistician with enough time. How did you, and then enough time to kind of understand what you're doing clinically. How did you deal with that? Like, how often do you meet with stats? How do you do that kind of analysis?
Yeah, actually, Kelly Bergman, it's the lead author in that, and it's actually mostly out of Colorado Children. I mean, at Minnesota Children's Hospital. And the way we did it was basically the lead investigator got an internal grant, and that paid for a lot of the study statisticians and the study coordinator. And I think that is the way to go, really. Just like, you know, just get an internal grant. It's not that hard to get in most places, and then that would get you a lot of support. So he's the one that actually handled most of the stats, and he had a research assistant coordinating, because there's a lot of paperwork coordinating with all these like different sites, you know, the data use agreement, the DUA, and all these IRB to deal with. So I think that is the key. I don't know how often he meets with the statistician. I know that it's probably, you know, you have the statistician sit down, you just work out methods with them, and then at the end you just calculate. I mean, it's mostly modeling at the end, and you have a lot of data, and you just feed it into the model. It doesn't take that long to run the model, but you have to have someone that knows how to do the modeling, and then, you know, that's over my head as well, actually. I mean, I theoretically know how to do it, but certainly you need a statistician.
I feel like I can play with models, but I don't know that I'm using the right model. So like, even just having a statistician be like, plug it into this model and not that model is so helpful.
Yeah, I think it's mostly just looking for biases, because we have so many different sites, and yeah, I mean, it's just doing a mixed effect models, and it's a little bit more complicated. It's not undoable, but you save a lot more time by having a statistician doing that plugging for you instead of just you mugging with it for like days on end.
Thanks.
You're welcome.
Sam, I got to say, I think that I know we're moving on to the next session as section of this session, but I thought it was really cool how many sites got involved, and the representation from like Costa Rica and Mexico and Australia, and then different states in the US, so many different health systems. I think that was really cool. So I got to say that was probably one of my favorite parts about the study.
Yeah, I think the great thing about Pete's ultrasound communities, we're still relatively small, and the P2 network is a great place. I mean, that's basically our P2 network, and there aren't that many people over the world that do PEM focus. So it's easier to know a lot of people and kind of just rally if you have a good project. It did take a few years. I think it probably took a good like 3+ years for that project to just recruit 200 something patients. If you talk to Romulo, it's the same thing. Like his recent project got almost 1,000, but it took a long time, you know, just like get about 20. So yeah, you have to be patient, and really just having a clerical, like a study coordinator, it's key in doing these things. Just having somebody take care of the paperwork, because otherwise you just like spend endless time doing this.
Yeah, I have to give another plug to P2. That was, I was on their last meeting, and they were just talking about the different research projects that are all being done. And so it's collaborative. So it's like all these different projects that you could, you know, if you wanted to be involved in, you could get involved in, which I thought was amazing, that they have this such a great network to be able to kind of work on collaborative projects together. I think that we are trying to do some of those types of things. I think in SAEM is trying to do this collaborator connection. If you're not aware of this, they have the collaborator connection, which is trying to kind of link people up who are doing similar projects across the country. And so we've been talking about trying to really kind of drill down on that for ultrasound, because that collaborative connection is for the entire SAEM. But there's a nice little section that we've been working on as far as getting, ultrasound groups together or people together to try and work on that. So if you guys have projects that you would like to throw in, I know that we've been kind of working on that and for SAEM. So that's something that's kind of looking forward to in the future. If you have projects you're trying to get people to help out with or whatnot, that too.
That's a great point about the internal grants, and the bar is relatively low. If you have a good project and you have a good plan and mechanics lined up, those internal grants can be a real great source of getting these things actually done. So that's a really good point about that.
There's like several, both ACEP and SAEM do small grants. So if you have a project that's really, that's a great opportunity for you to get things off the ground. It's not going to be a ton of funding, but if you're talking about getting a statistician, I mean, that's, the stats people, I feel like, are worth their weight in gold. So if you can get, that at least your stats paid for, then that's something that could actually get your project off the ground. You may have to, suck it up and do the extra work yourself, but just getting a statistician to kind of get you started, I think a lot of times is really kind of what gets you going or motivates you to make sure that project is useful.
Yeah, and depending on your staffing or your employment model, that internal grant can be a great stepping off point to associate professor or even full professorship, which can then get you less clinical time, and then you're home with your family more.
Yeah. I think the research assistant is definitely worthwhile. You pay them $20 per hour, and then 20 hours per week is only $400 per week. And then, yeah, it definitely saves you a lot. I mean, it's less than a shift's pay to just maybe like a shift's pay to just get them to a month's worth of work. Statistician, maybe like a couple of $1,000. It's actually not that expensive either. So even if they're like $50 an hour, yeah, I mean, it's definitely worth it. So it works out to about a little bit in the low end 5-figure, I think, in terms of the grant, but it's definitely worth it.
Yeah, I think, and you probably have the same thing, Sam, where, I will personally, my grant's always been small, but like, I'll be willing to not get my shift buy down if it pays for research assistants or stats, because those are things I can't do. I can kind of work around my time and, do other things, but I think those are really important parts that I can't do myself. Is there any other questions people have, ideas, thoughts? We can keep talking about this paper, or we could, if someone else has anything else they want to ask.
I definitely want to leave the floor open, but we are currently working on a project with Mindray to do take their iWorks software for like automatic labeling, and then do a pre and post for cardiac. And we're just finding that our lawyers and our IRB just have no idea what to do with this project, because there's too many hands in the pot. They're like, well, it's proprietary like technology, they should go through like the IT department. The IT's like, what the heck are you talking about? This is research, we don't know what to do with this. And so like I'm finding myself just running in circles trying to figure out who is responsible for this stuff. And then like for you guys, when you try to do partnerships with industry, who helps you at your institution?
We try to tell the IRB who's responsible without the IRB telling us who's responsible. I think that's kind of been the approach that we've taken the most, is the IRB will be like, whoa, what's this technology thing? And you're like, oh, it's technology. You don't need to worry about it, something like that. Like it doesn't affect the patient. And they'll be like, well, did the IT group do anything about it? And either the answer is, yeah, they approve this technology, or the answer is this technology is not used for clinical use, so it's not affecting the patient's clinical picture. and it's not like it's not the thing that you need to worry about. So I do a lot of like this with IRB, and like after a couple of cycles, we're like, oh, okay, yeah, I guess it's not affecting the patient. I don't know if that's a good enough answer, but yeah, I don't know.
So
Tell
you take
them
the
instead
smoke
of
and mirrors
asking him, I
approach?
think is kind of the thing.
I mean, it sounds like it would work. I was told by my research team, this goes through legal, whatever legal means. And legal's like, I don't know what to do with this. And like, oh. So I don't know. Anyone else have
So
ways
is it like
smoke and mirrors?
So what is your project? What are you exactly doing? That's what I think Nikolai was going to ask. Like, we're all
Okay,
like,
so
salivating. Like, what are you doing? We're
my
interested.
personal ability to label my scans sucks. So I'm a big part of that. Like your improvement during fellowship is great, and then you graduate and you suck. And so that happened to me. And so I'm trying to get better. And one of the ways I want to get better is I want to have the iWorks protocols from Mindray. Now, Butterfly has similar protocols, and I think everyone's got their own secret sauce, but we have a lot of Mindray products. So I was thinking, okay, well, if I can get that product to improve my own personal labeling, I can improve the labeling of everyone else's scans, and we can get closer to like 4s and 5s on our QA instead of just 3s all the time, because no one labels their scans, including me. And so we're going to take our cardiac studies, which is the thing we do the most. We're going to do a pre and post. So pre-institution, what proportion are fully labeled of like personal long, personal short, apical 4, subxiphoid. How many of our cardiac scans actually meet full, labeling. And then afterwards, the iWorks protocols are instituted and available. What proportion at that point of all the cardiac scans are fully labeled? And so if the number is significantly different, then the labeling stuff works. And then Mindray is happy because they charge money for that product to be uploaded on their machines. And then we're happy because we got it for free and get to keep it, which I changed their contract to say we get to keep it because they very conveniently left that out. And then I get to actually have better studies for myself. So it was all selfish to begin with, but hopefully in the end, it'll be good for everybody.
So this is not a modified system. This is like an FDA approved system with an extra software package. Yeah. I would just tell the IRB, hey, we're gonna study this thing that already exists and doesn't affect patient care.
Yeah.
In the moment, right?
Yeah, I might reach back out to my institution, say like, you guys, we just got to tell the IRB what we're doing. We're not gonna let them have control over us. We had that happen for a long time with case reports. We had to go through the IRB for case reports. And it was insane. It's insane. And so eventually we're like, we just got a blanket letter saying that this is not something the IRB has to deal with. And then they had a big offload of crap to deal with, and we got a big offload of crap, and everybody was happier at the end. So yeah, our IRB is a little nutsy, but that's okay.
Yeah, it always depends on your IRB for sure. But I think like this one sounds almost like you could spin it like a QA project and not have like just have an RFD that's not research.
Yeah, but the only trouble is that the contract with Mindray to get this stuff for free has to go through somebody. Who's the somebody? Apparently the somebody is legal. Whoever legal is. I don't know.
Can the somebody be your chair?
That would be wonderful.
Could you pay $1 for it and just get it at a steep discount?
They're all good plans.
Is there concern is that it's you're getting something for free? Is that the concern, that there's a conflict of interest? Is that what they're
I think it's just
about?
that it's a legal agreement for a product that typically costs money. And that we're going to get that product and we're going to do a study on it at the hopeful, beneficence toward the manufacturer. So lots of conflict of interest there. But at the end of the day, I already have previous data from the radiology literature that say this is probably going to work. And then I get to have a study under my name. I get to have a free product at the end.
That's key. Win-win.
Yeah, everybody wins. Why can't we just do it?
Yeah, I think you just tell them. You're like,
Smoke and mirrors. I like the plan.
this is what I'm doing. This is fine. This doesn't affect patient safety. It doesn't affect patient confidentiality. Like the things that the IRB cares about are your subject safe and is their information safe?
Yeah, I think that's a great point, that whole HIPAA compliance, and that, you know, you're not giving away any patient information, because I think that was our big issue when we started talking about Butterfly, was that our, you know, our department, like the IT, was all freaked out about, you know, oh my gosh, the you know, you're putting it on the cloud, what about patient data and whatnot. So we just never actually moved forward with Butterfly, as far as in, you know, some of our IM guys have used it for like educational purposes, but we haven't moved forward as far as using it for a billable scan. So we actually don't use it in the ED at all. But that was the big issue. It was like, you know, the healthcare data. So that may be their part of their problem.
Okay.
We've also had some like issues where like, so we work with Philips a fair amount, and they would modify some of the software packages to do like additional calculations or additional scale things that aren't on the FDA approved system. So for that, we had to say, hey, this is safe because it's just a post-processing thing, and we're not using this post-processing thing in clinical care. But it sounds like this labeling iWorks thing is already for sale, approved by the FDA, not a modification of a pre-existing system. So really nothing outside of your conflict of interest.
Yeah, I'm gonna send a message to my research team and say, like, this is taking too long. Can we take this out of legal's hands and say, like, you know, all the things like, you know, it's patient safety, FDA approved, you know, maybe go through our chair, you know, like you mentioned, to see if we can just get it approved from the, we have I think we're UEMS incorporated, so we're a private entity. And so if we approve it through our private entity rather than through the university, I wonder if that will clean everything up. Though the only trouble is that we don't own the machines in the department. So
yeah, that's the problem. Yeah, but
Can I ask a methods question?
Yeah.
How many mind rays do you got?
Well, we've got two. So at our cardiac vascular site, we have 2 Zenaris that we're hoping to trade out for 2 M9s. We have 1 M9 and 2 TE7s. Then at our trauma center, we have 4 M9s and 1 Zenari. I think it's like a ZS2 or something.
Could you, this might be a good idea, it might be a bad idea because there's some like people getting used to stuff, but could you randomize your machines to have the protocol versus not have the protocol? And rather than doing
we're gonna
it
get
before
3
after.
licenses at best.
Oh, okay.
They're only gonna give us 3 because apparently they want to be really stingy with this stuff.
So you could randomize them.
Yeah.
Well, I mean, it could easily just include that as a you know, do pre-post and then compare 2 sites. One site that's getting it, one site that's not. And I guess all of create a control at least.
Do all of your physicians work like half and half at different sites, or
no? It's a smattering of people. Some people work multiple places. Some people work one place. Some people work other places. Like I work at VA and the vascular. Some other people in my division work at the vascular and the trauma. And then some people work at children's. Some people work at community. Some people work at the Rich People Center. It's all over the place.
Our group's the same.
Can I ask, what the heck is a cardiac and vascular site?
It's where all the STEMI, strokes, and vascular nonsense goes.
I see.
Mm-hmm. Yeah.
It's like, oh, it's just an emergency department for vascular stuff? What's that?
Well, so we're so siloed over here, it's insane. Like our children's hospital is now shoving all 16 and olders over to us because of, you know, the fluvid nonsense. And then our trauma center, like, you know, we'll see everything that comes in through the door, but our EMS system is very siloed that if you're having a trauma problem, you go to the trauma center. If you're having a stroke or a STEMI, you go to the stroke STEMI center. If, you know, it's not one of those things, you can go to whatever. Mm-hmm. So it's highly subspecialized. We're part of the Great Lakes something consortium who made all these decisions decades ago to like super silo everything.
Wow.
So from a cost point of view, I think it's sort of effective. But it's just, if you practice at those locations, you don't get exposed to the other things. Like I get next to no trauma.
Yeah. It's wild.
Yeah.
It's a tough way to train folks.
Yeah.
Well, the
Speaking of
residency puts them through all of
cardiovascular
it.
sites,
But
here's
as
a
an-
question for y'all. What's up?
Go ahead.
Oh, recently, one of our interventionalists who's been around a bit longer said, "Hey guys, I noticed that you started doing point-of-care cardiac ultrasounds on all of my STEMI patients, and I'm worried that it's going to cause delay to intervention, and that's going to go into my registry. Can you guys stop doing that?" And this went out to our department as like, please stop doing point-of-care echoes on STEMI patients. So A of all, I'm the cardiology liaison, and I unfortunately missed the meeting where this directive went out. So I'm a terrible liaison. But B of two, I contacted the chest pain coordinator who monitors like to the minute every single like delay and is like messages me like what happened with this patient. And I was like, have you seen a single case where there's a point of care echo done that causes a delay? She's like, no, I haven't seen a single case. There's like nothing about this anywhere. This is just this person decided that that's the reason that we have delays and you guys need to stop doing this.
It sounds like you can just forward that email to him or her, who up to the old interventionalist, just forward that email and then you're like, you're wrong.
No, I think I need to like somehow structure it. But you know, I started doing literature reviews. Like there's no literature on this. Like it could be a problem, you know. We should show that it's not a problem. And we should also show that there's value to doing this, right? Because like there's a bunch of case reports of like, we thought it was a STEMI, and then it turns out it's like a
dissection,
a proximal dissection that like we really shouldn't be giving things that make you bleed more, right?
That's fascinating though, because like ours do the exact, like, so we page out a STEMI, the cards fellows come down and we'll have, be scanning and they'll actually come and take the probe, like either go, let me see what you're seeing, and we'll show them.
Yes. And in fact, that is what happened. It's just this one guy.
Oh. The old dude who doesn't know how to do point-of-care ultrasound, I'm guessing.
Yeah, but I mean, looking on the bright side, looking on the bright side, he may have just given you a project. It's like, you're going to do this project real quick. Hopefully it's just, it's all retrospective. It's like, so you're wrong. And I published this case, this paper on it. So
yeah. So if anyone wants to join on a retrospective STEMI registry, look at who gets an echo, happy to join forces.
I feel like that would make a really good episode of You're Wrong About, Nikolai.
I know in my head, there's been so many times when I've wanted to do a talk on like, this is why you should echo every STEMI.
I love the idea of like a podcast on like, just like POCUS : you're wrong.
Dan, have you listened to You're Wrong About before?
No, what are you talking about?
It's a podcast. It's called You're Wrong About. Pretty good.
Great.
Yeah, Nikolai, I think you actually told me about it too.
No, I think we both talked about it and we were both like, oh, you listen to that podcast too. Yeah, it's great.
Does it cover like, is it everything that you could be wrong about?
I mean, it's got like 3 seasons, but I'm sure there's more things that one could be wrong about.
I feel like it's mostly like pop culture kind of stuff.
But yeah, pop culture and political events.
Yeah, I can imagine just an entire medical podcast that all it does is dogmalysis.
Yeah,
that's all it does.
Yeah,
that's perfect.
You'd be employed forever.
Hey, Dan,
I would call that one dogmalysis, though.
Oh, that would be good. Yeah. Dan, I have a question for you about your mind race and your Zanaris. What transducers do you have them all set up with? Would it be a complicating factor to have different machines with different setups? I know one thing that I've kind of strategically tried to do while we're acquiring machines here for our site has been having like different transducers. So like Zanari has a really cool small footprint curved that Nikolai knows I love for particularly lung ultrasound, the C41S.
We actually have that with contrast abilities.
Oh, I'm so jealous. I love that transducer.
You use it. Yeah, sorry. There's a lot of frustrating things at my shop. That is only one of the many.
Sounds like a project.
what I'm thinking about is like from a methodological standpoint, would you want to just like license, if you're only getting 3 licenses, maybe are you planning on just getting, putting those licenses on the machines that have all similar setups between the phased, linear, and curved?
Yeah,
Or
since we're early in the phasing of this
Uh-huh.
process, we want homogeneity as much as possible. We would like to avoid heterogeneity, and therefore we're going to try and have, it's probably going to be the M9 and the 2 TE7s, which I believe have the same cardiac probe.
Well, there's 2 different. There's the SP51S is the newer one, and then I think it's P41S maybe. I forget the other one. We have both the new and the old one.
Yeah, I mean that is a nice curve. We have the curved attached to our Zanari, so that's like it's a great probe attached to a crappy machine. So there's that. And then
Don't you dare disparage Zanaris. I love them.
I'm sorry, it's a cow. It's this huge monster of a thing, and nobody wants to do it. So I don't tell you.
Yeah.
But yeah, so that is nice for lung imaging, and if we actually had contrast abilities and maintained that would be nice, but we don't. So yeah, we're aiming for homogeneity on the first round. We can get heterogeneity later on.
Nice, cool. I think that'll work well.
Have fun with the baby, Nick.
Yeah, thanks, man, for helping out. I appreciate it. I'm gonna probably have to bop off soon because I'm hearing the troops just I hear a fight brewing.
It might be the baby
here with my
monitor,
two
though.
crazy kids.
I don't know.
Oh, you
actually heard my baby.
We'll
Oh, no, I can hear them right now. You probably can hear that in the background. There's some fighting. I hear door slamming. So
Petra, do we have someone for lung?
no, not as of yet. So if you that was the only thing
I can swap that shift.
If you could, that would be great. I'm happy to. I actually got a list of all that. So what I've been kind of using is there was a list of all the articles that got nominated for SAMEs this past year.
Oh, nice.
Okay.
And so since those were scored so highly, I actually been kind of pulling from those. So both of these articles were, well, Stephanie's was on there as well, but they were both from that list. So if you want, I'm happy to share that list.
Yeah.
If you want to pick out one of those, that may be a good choice for it, unless you have some other idea for something you want.
No, I thought it would be
I just
easy enough to get. I think we won the SAME last year. It was the beeline counter, the automated beeline counter study.
That one I've got. So I can share with you the I got Dan Theodoro to share the SAMEs list with. And so I'll do is I'll drop that into the our folder, for the literature folder, and that way we can kind of look at that, because it was just kind of a nice resource to have. But it doesn't say who won, but it just gives you all the different ones that were nominated. Or they, when they did the sort, they were the top 5 scored articles in each category. And so you kind of have to go through them and see, some are retrospective, some are prospective, but it's actually a nice list.
Yeah, I think
so.
I think we've done a decent job with prospective stuff, and we've shown what that looks like. But I think for our audience, being a lot of fellows and early faculty, we should start focusing a little bit more on the feasibility side of things with retrospectives and that sort of thing, and registry reviews.
Yeah, gotcha. I think that's actually a fair discussion. Fair point.
I have the date available. It's that Saudi Arabia Kenya trip that I'm going on that is making me a little hesitant to sign up for it, but I think I have the date available. So Nicola, you don't have the date, right? You have, but you don't have any big communication issue during that.
Yeah, no, I just have a shift.
Okay, why don't we work together then on it? And then either I can be a backup or I can take it over, depending on how easily things get set up early on. Does that work for everybody?
Yeah. Are you going for fun or for ultrasound? Or I guess, and for ultrasound?
So fun. Saudi Arabia is because we had some neighbors 2 doors down for COVID that basically helped us survive COVID, that we want to go see. And they moved back to Saudi Arabia. And then Romeo Wahome, who's like my, colleague, friend, mentor, everything, for global health. He's not that far away. So half the vacation is going to be spent in Kenya hanging out with him.
Oh, gotcha. Okay.
So I want to actually meet him. I've never
Yeah.
met him.
Oh no.
So
That sounds awesome.
yeah, it's gonna be
All right,
tough.
so I just dropped that into the folder. It says Sammy's 2022.
Okay.
So, and it gives you best case report / series, best research on medical education and training, best retrospective. There you go.
Cool.
Best cross-sectional research, best prospective research, best meta-analysis, systemic review, best randomized control, best broad scale innovation. So, there you go. And then I know that they're already, Francis was saying they're already starting to, yes, darling, you can come into my lap here for a moment. Yes, that's fine.
Hi.
So, can you say hi? Hi. Okay, great. Yeah, so I know Francis already started pulling data from the first 6 months of this year. So I may be able to get a list from that to see if there's any other studies that might be good for us to review. I would love to continue to kind of pull people who have, you know, in our community that we can actually get to actually come and talk about their article. I think that that's actually a really nice thing to be able to kind of pull people from our community, you know, to highlight them.
Yeah, this one was so cool because it's like such a big, small community, this P2 community.
Yeah. No, I went to their, because I was, I spoke at their meeting on all my, you know, my virtual ultrasound stuff like last week. And it was great to see like all of, they really worked together really nicely. I mean, they had like a list of like all these articles that they're working on currently, or, you know, projects are working on. I would love for us to be able to do that more as our community as well.
Cool.
All right. All right, well, I'm gonna let you guys go so I can go deal with
anyone on board.
Drama is here. Yeah. But yeah, so just let me know. And so Mike is kind of stepping down from doing all the kind of running this just because he's got you know, now that he's section chair for ACEP. So I'm gonna be taking over doing all that. So the stank eye right here. So I'll be taking over that. For just send me all of your info and I will. So as soon as you guys can choose the article, if we can get it done in the next 2 weeks, that would be great because then that will allow us to be able to send that out. I'm trying to send it out 2 weeks ahead of time and then right before to remind people. So if you could just send that to me, choices and who you're going to be talking, you know, at least the article choices, that would be great. And I can at least send that out there. Okay. And then also there should be a list now of people who have volunteered because you already have some people who volunteered wanting to do small group for pulmonary. So that's also in that folder. So, and I think I have to add Francis had also texted me to say that she wanted she'd help out next month too. So I'll actually add her. So you actually have a good starting point with people to lead small groups.
Amazing.
Sweet deal.
All right.
Quick question. Do you think case reports are something we should do on this program?
You know, I think that later in the year when we're doing kind of towards the end, there's like medical education, or some other things that we could actually do for case reports. That would be an interesting discussion about having a couple of case reports and talking about what makes it good, what makes it bad. That may not be a bad idea.
Because I mean, it's the thing that gets most people into research is case reports. It's their first like actual writing opportunity. So
yeah,
in terms of
that, you know, that would be good because you've got to, you know, get this list of best case report / case series that, you know, that would be great to kind of pull some of those, especially if you had fellow presenters who could actually, or people who've just finished the fellowship. That may be actually a great way to draw in more fellows to kind of say, this is what I did and why this is, you know, I thought this case was important.
Yeah.
So that's not a bad idea. I like that. That's actually a good idea. How about that? I'll say that. I'm not saying it very positively. That's a great idea.
Okay. All right. Well, Nick, we'll have a conversation, I guess, about which Sammys we want to make for Palm. If you have any opinions or whatever, we'll figure that out and then try to get it the next couple of days. Okay.
Yeah, if you guys just let me know, that way at least I can get that out and so we can kind of get some more traffic. And Jason's been, I think, posting about it too. So Jason Arthur has been helping out with some Twitter stuff. So that's great. The more we can get it out there, the better.
Okay, sounds good.
Awesome. Thanks so much, guys. I really appreciate it.
See ya.
All right.
Bye.
Bye.